selflessly caring for patients the world over in these distressing times. The commitment and sacrifices from the healthcare community is deeply appreciated. And actually, it's up to all of us to help you by slowing the spread of COVID-19, by following the hygiene and social distancing recommendations that the governments are releasing. In many countries, important scientific events and forums have been postponed or cancelled, such as recently what we saw with the European Congress of Radiology in Vienna. So the team here at Bayer Radiology in Asia Pacific, we decided to build this webinar series to continue to contribute to scientific information sharing and discussion when our normal face-to-face interactions are just not possible. So really, it's my absolute pleasure to welcome you to the first session of the CT Protocol Optimization webinar series and presented by Professor Charbel Sadi. So every month, we're planning to introduce a new topic area, such as next month, we're going to dive into CT oncology imaging. But tonight, however, we're planning to focus on renal CT image optimization, and followed by actually tomorrow night, another session where we're going to look into liver CT. So our presenter is Professor Charbel Sadi, who is well known from many international congresses such as RSNA, ECR and Arab Health. He's an expert in the field of X-ray, CT and MRI, and has co-authored more than 90 publications. He's Assistant Professor of Medical Imaging and Chair at the American University of Beirut, and has a deep clinical and technical knowledge of performing CT. So tonight, the first hour or so of the webinar will be dedicated to presenting information. Then we're going to follow this with around 30 minutes of radiology case presentations, leaving around 30 minutes for a Q&A session at the end. And please feel free to type your questions into the chat function, and these will be collated and addressed during the webinar. I encourage you to relax, enjoy this learning experience. Please ask questions and make comments, because we can all learn from them. So with that, please let me hand over to Professor Charbel to start, and thank you, everyone.
Thank you very much, Leona, and a big thank you to Bayer Healthcare for allowing me to present a series of education webinars in this very tough time. And it is a pleasure to be able to continue learning in this very distressed time for the world. And it shows how Bayer is really, really investing in people's education and knowledge, which can benefit mankind. So a big thank you, and it's my absolute pleasure. So everybody, good morning, good evening, or good afternoon, wherever you are in the world. It is my absolute pleasure today to talk to you about liver CT contrast media applications. So what is really important about this is that evidence-based learning has come such a long way. You know, in imaging, where we learn through the textbooks, through journal articles, and also through experience. And people in every institution or department around the world, if they share their knowledge to you, this is an added advantage. However, there are a lot of things that keep changing, and there's a lot of pitfalls and techniques which we can perfect your imaging. So for this lecture, this is a disclaimer. For this lecture, we'll quickly talk about anatomy. We'll look at contrast enhancement patterns and protocols. We will then dive deep into technical pitfalls. I will show you exactly how easy it is to identify potential pitfalls in imaging and how we can overcome these with certain remedies. Then, of course, we'll go through cases. So I think if we look at why are we imaging, what is our philosophy, what is our drive, if we consider these three components by reducing radiation dose, contrast volume, and increasing image quality, if we put those three parameters at the center of our universe when we're designing imaging protocols, then we are able to accurately, effectively, every single time, give consistent image quality to radiologists for their reporting. So let's have a quick look at the anatomical components or the vascular blood supply to the liver. So as you know, you have the superior mesenteric vein, inferior mesenteric vein, which then comes up and joins with the splenic vein, which then dive into the portal vein, and it splits between the right and left lobe of the liver. Now, this is important because only 15% of arterial blood or oxygenated blood gets to the liver. However, the liver is more of a venous organ because the other 75% actually comes from the mesenteric and splenic system. Meaning, so contrast has to go through, it goes through your small bowel and large bowel, and then it filters back up into the mesenteric vein system and back into the liver. So when we're thinking now of doing an arterial phase CT of the liver for detecting disease or oncology applications such as hepatocellular carcinoma, metastasis, we have to wait a little bit longer than what you would normally wait when doing an angiogram to look at the vascular system, because we needed to pass through the mesenteric system first into the venous system and then back into the liver to accurately give us good opacification. Now, one thing people don't really pay attention to from what we have done over the years is that when you're looking at a lesion on any form of CT, whether it's in the liver or anything else, we're not just looking at how the liver actually enhances, but we're looking at how the lesion enhances relative to the liver parenchyma enhancement. I think this is something key and important to understand, because later I will show you why the viscosity of contrast media, and more importantly, why the density of contrast media has a large role in how contrast moves throughout amount of blood which is leaving the cardiac output that's going through the liver. Well, if you think about it, the liver is about 2.6 kilos, and it's pumping every minute 1.5 liters of blood. So this is a highly vascular structure, and there is high turnover of blood within there. So this is where it's important to get the contrast at the right place and at the right time. So let's look at some contrast media delivery strategies. In the world, when we're designing protocols, we have to basically look at two key factors. First, the patient factors, such as there is small vessel branching, there is cardiac motion and respiratory motion. Previously, you've been taught that you're unable to control these parameters. After this lecture, I'm going to show you the physics behind breathing and how it affects the cardiac and respiratory motion. And then also we have technical factors. How do we tell the patient to breathe in and hold their breath? Then we look at contrast enhancement, the flow, the viscosity, the density of contrast. But it just doesn't stand here. You have to remember you can't use contrast solely on its own. It's a combination of factors that you use the contrast media density, which should be at 370 for all oncology applications. 2, it should always be a monomer, because a monomer is a lighter molecule. And the beauty of the UltraVis 370 is it moves like blood. So when you're imaging, at least you can be confident that the contrast that is moving and distributing through the large organs or the high blood system or high blood turnover, the contrast is getting in the right place at the right time. And finally, CT parameters. We will talk about this a lot more. Now, contrast cannot work on its own. You need to actually couple it with low KVP factors, because with a lower KVP and a high contrast density at 370, you are definitely going to get better image quality and greater opacification profiles within lesions and the liver parenchyma. But more importantly, it's always important to use safe contrast. So let's talk now about the first patient factor and how we can solve this issue. So whenever we breathe in and hold our breath, usually patients will breathe in, hold their breath with their mouth closed. So what happens is within 3 seconds, heart rate increases its heart rate. The stroke volume thinks, or the heart or the body thinks that, fight or flight response. So automatically the intrathoracic pressure increases, and then you can have this large flow of blood coming into the heart. So imagine you're delivering contrast media, you set up all your parameters perfect, and then all of a sudden the contrast has disappeared and it's not opacified the organ or the vessels the way you wanted it to. This is because of breathing. And what happens is when you breathe in and hold your breath with your mouth closed, your heart rate increases and so does the flow of blood in your heart. So however you're monitoring, it is going to actually push it a lot further or a lot shorter in time, meaning we're going to miss it. So how does this happen exactly anatomically? If you have a look here at these diagrams, this is the venous system. So you can actually see on the image to your left, the superior vena cava, and then right next to it, you have the azygos vein, which comes from the abdomen and also drains deoxygenated blood from the thoracic cage. So what happens is if you think to yourself, okay, we're going to breathe in and hold our breath, the azygos vein actually dilates. As the contrast is traveling in the superior vena cava, it stops it. And then the azygos vein starts to increase its flow of blood in there. So this is why later on, we're going to have a vascular CTA series for Bayer. I'm going to show you that a lot of these artifacts and a lot of these poor contrast enhancement strategies or issues are occurring because of breath hold. And you're going to say to myself, how do we solve this? Very simply, when you breathe in and hold your breath, okay, people do it with their mouth closed. So let's do a test now. This is the first time I'm going to do this online. If you get your 2 fingers, just put them on your carotid pulse and feel your heart rate, okay? Now, we're going to do 2 breath holds. What I want you to do is for the first breath hold, make sure the first and the second breath hold volume going into your chest is exactly the same. So we're going to now hold our breath for 10 seconds, okay? So let's breathe in. Hold your breath. Don't breathe. Breathe away. So automatically, you would have felt that your heart rate and your blood pulse went up. This is what we do with our mouth closed, and this is what most of the patients are doing. So how do we solve this problem? Well, I'll tell you in a second, because I want to show you now anatomically what happens even more, because now I want to explain it. So if we have a look here at your image, the superior vena cava is receiving blood from the right and left brachiocephalic vein going to the superior vena cava. It then will flow into the right atrium. Now, you know that the intrathoracic veins or the intracartilage veins, they're at a low blood pressure, okay? And then your azygos vein is also at low blood pressure. So everything at low pressure is moving in very slowly. So the contrast coming in can do it perfectly. But when you breathe in and hold your breath with your mouth closed, what happens then is, as the contrast is coming through, you start to increase the pressure of the intrathoracic veins. And what happens then is the azygos vein will dilate, as we go on now to the third image, and then we go into high pressure. So the contrast that's coming up in the azygos vein stops the inflow of contrast media from right and left brachiocephalic vein, and it just stops there. So if you ever notice, you get a lot of artifacts in the actual cervicothoracic junction or the brachiocephalic vein. And then the contrast moving in and out stops, completely stops. And there's contrast in the arterial system. This is because of breathing. Now, how do we fix this? Let's put our 2 fingers again on the carotid pulse. We're going to do what we did last time. Now, I want you to do it with your mouth open, as if you're going to the dentist, okay? So we all ready? Okay. Now, breathe in and hold your breath. Keep your mouth open. Breathe away. So what's happened now is you've actually held your breath for 10 seconds, the heart rate doesn't go up, and blood flow is still moving normally because we're not raising the intrathoracic pressure or the pressure within our lungs, because our body doesn't think, we're going to have to run away from something using the fight or flight response. So does anyone have any questions about that? I have the Q&A open, but I'd like to really understand this, because the reason why I went through this is because 90% of a lot of failed contrast media delivery strategies is because of breathing. And it's important always to spend a little bit of time with your patients, just to explain it to them. Make sure you have your mouth open when you breathe in, make sure it's very soft and doesn't have to put a lot of air in. And this will not affect your contrast media delivery. Okay. So let's now look at how do we calculate the contrast media volume. There are three schools of thought here. There are people that say, okay, we can use weight-based protocols. So, for less than 60 kilos, we use 70 mils. Between 60 and 90 kilos, we can use 85 mils of contrast. And of course, anyone above 90 kilos, let's go for the full 100 mils of contrast media. Also, there's people that use the linear system. So for every kilo, we can use anywhere between 1 to 4 mils of contrast. Again, this is FDA approved, and this is what you see in the product disclosure statements. And then, of course, you have people that are very well experienced, and through this experience, they will tend to gauge to say, oh, he looks like he could be 60. This person can look like it'd be 70, and so forth. Now, I just had a quick question come through. Oh, okay. So I have one of a radiographer, it looks like it's from Australia, that says, we've recently moved to leaving mouth open for CTPA techniques, and we've had excellent results. This is excellent. So I'm sure that they've come across this lecture, which is fantastic. We'll have another lecture to say, how does this artifact occur? Well, we're going to talk about this artifact in the next 3 to 4 minutes. Now, this is a Dr. Sublock. We'll talk about it in 4 minutes' time about how this artifact occurs. So with these three common contrast media applications, people are doing, based on weight-based protocols. Look, it's really up to you what you do in your institution. But what I really like to say here is that it's not just about the contrast volume that people should worry about, because if you look at renal safety, there is no evidence, according to the American College of Radiology and the European Society of Urogenital Radiology, that contrast media actually causes contrast-induced nephrotoxicity. It's a risk factor, definitely. And there's another school of thought to say, well, how can we reduce this? People are saying contrast media volume reduction. I don't agree with this. I tell you, the biggest issue we're facing today with renal safety is because patients are dehydrated. So if you're dehydrated and you have a high concentration of urine in your actual kidney system and you're injecting contrast, this is where the issues occur. So in actual fact, what I would recommend is we use a dual barrel or use a double barrel for every injection that you do. One, make sure your patient is well hydrated before they actually come to the examination. Two, I always use 100 ml saline flush, which we're going to talk about in a minute. And three, by doing this, we're actually keeping the patient safe. The new guidelines now are going more towards patient hydration status than anything else. And also there is the rumors out there to say, you have a monomer, which is the Ultravist, and then you have a dimer, which is the competitor, to say which contrast media is safer. To be honest, under all the guidelines and all the research which has been undertaken in the last 20 or 30 years, there has been no direct evidence because there is no control group to prove who is the safer contrast. The thing is, we have to understand that the patient if the patient is safe to be able to give contrast due to its hydration status, then we have to look at contrast in a different way. We want to see, well, if contrast moves like blood, like UltraFist 370 does, then it's going to get to all those little spaces that we want. And this is where we start to look at contrast. So let's look at how contrast media works. So by the way, all of these videos and images that I'm showing you, these are all based on and taken from the publications that we have done. Now, ideally, when I like to inject contrast, at the beginning of my scan to the end of my scan, I want to maintain peak contrast enhancements in my liver parenchyma as well as in the vascular structures. Now, this is ideally what we would like to occur. However, in reality, this does not occur. Contrast will only rise temporarily for about 1 to 2 seconds. And so when we're scanning the liver, we're not going to get good distribution of contrast media throughout. And this is where I come back to one important factor: monomer versus dimer, or the lion versus the elephant. Who is the king of the jungle? The lion is the fastest and the king because it's fast and it can get away from everything. More importantly, when we're looking at UltraVist as a monomer, it can move like blood and it can get to all the small places, meaning the blood supply to any tumor is very complex. And these complex vessels that are supplying these tumors, you need to know that you have a contrast that can get through all of these small vessels to enhance it or enhance the lesion uniformly. So how do we solve this? Saline. Now, saline is important for a few things. One, we've talked about that having saline allows our patient to have a proper hydration status. Now, when we inject saline, 100 mils, which is not a lot, remember, if you drink a bottle of water, that's 350 mils. So 100 mils is 3 times less than what you think. It's not a lot, but people think it's a lot. When you inject saline, what it does is it activates the antidiuretic hormone from the pituitary gland. And by doing this, it actually increases the kidney function. Now, when you increase the kidney function, it starts to filter out the iodinated contrast media from your vascular system. And so it pushes it to the kidneys a lot faster. More importantly, with that extra saline in the interstitial space or within the actual blood volume, then the actual saline will get into the kidney a lot faster. So it's going to increase the dilution of contrast in there. And then more importantly, when you actually have this much of saline that goes through, which is not a lot, then you go to the toilet for excretion a lot faster. This is where the safety is. So using a double barrel of contrast and saline really gives you safe control of your patient when delivering contrast media. Now, I have a question. How do we decide between 370 and 300 density for liver CT? And this is from a radiographer in Nepal. So thank you so much, Mr. Thapa. I will discuss that and I will show you that very, very quickly in the next few slides. We also have Mr. Kumar. For the puff cheek technique or Valsalva, how can we open the mouth? Well, Mr. Kumar, let me tell you, it's really important that we don't do the puff mouth technique because I showed you it stops the contrast coming in through the superior vena cava. And this is actually more worse to do it when you come to do it with CTPA, especially with pregnant patients, which is another problem. But we have a dedicated lecture for this in the coming series with Bayer. So as we go along, when we give saline, what it does is, if you can see the blue line on the image, it pushes my contrast and it maintains my peak contrast enhancement. So not only is this a safety tool by using saline and the dual barrel, okay, remember you need 2 syringes here with your injector, not 1 syringe. You need 2 syringes. This saline then allows the contrast to stay peak contrast enhancement over a longer period of time. And what happens then is it also pushes the contrast in order to distribute it equally and evenly throughout the liver. So by using saline, there are 6 key factors that we need to consider. 1, we push contrast by pushing the contrast through the subclavian vein to make sure it doesn't stop. 2, I always use 100 mils of saline. The only time we never use saline is when a patient has left-sided heart failure or chronic cardiac failure, or if a patient has pulmonary edema. That's the only time, and these are the 3 factors you never use saline at all. And even with contrast, you should be careful with the contrast volume you deliver. And by using the 100 mils of saline, you're able to reduce your contrast volume if you want to. You also increase the density or the attenuation of contrast in both the liver and the vasculature. So now we come and say, well, how do we decide between 300 and 370? You know, I believe that the difference between 300 and 370, okay, 370 gives you a greater density, gives you more confidence in being able to detect these lesions. The last thing you want to do is give a 300 density contrast media. And then you go at low KVP and you don't get good enhancement of the actual tumor. And that is because the density of the patient's blood we still cannot predict, meaning you can come in, if you're hydrated or not hydrated, the density of blood relative to the density of contrast will give us this mismatch and will show how dense the contrast is in the liver or the lesions. So then that's why it's always better to invest in 370 density in order to do this. Now, I have another question from Sadath. Please, can we stop the background music? Because I think the background music is still on. If Aaron, can we stop that, please? Because they can still hear it. Thank you very much. Khan Nguyen. So how much do we give saline volume for patients? Dr. Khan is from the Children's Hospital in Vietnam, and I've had the pleasure of meeting you. Lovely to have you on. So I usually, for pediatrics, for every kilo, 1 mil. So if it's a 3 kilo patient or 4 kilo pediatric patient, I go 4 mils. If it's 16 kilos, I go 16 mils for that. So the only time, we had a connection problem. So the only time we don't give saline is when a patient has chronic cardiac failure, pulmonary edema, or left-sided heart failure. And number 5 in giving saline, it reduces the streak artifacts from the veins and in the right side of the heart. Now, this is not as important for liver imaging, but I'm going to show you flow rates of contrast media is becoming a problem, especially in imaging. Also, we increase the rate of contrast media excretion, which is more important. Now, I have a person who says, Rasha Itani, do blood lipids affect contrast enhancement? Fantastic question. When you're doing liver imaging, there are a lot of patients that actually have liver cirrhosis. And so what happens is the vessels, they actually get small and they start to shrink. But I don't have to worry if I have contrast UltraVis 370 because it moves like blood. It's the only contrast media on the market which can move like blood, and it's able to actually get through those smaller vessels. This is more important. Now I have another question of Samuel Underhill. Do we use the same flow rate of contrast as saline? Absolutely yes. Now you can be technically even more perfect. If I have a contrast media delivery injection rate of contrast at 3.5 mils a second, I would push that to 4.5 mils a second for the saline injection. Because remember, the viscosity of saline is different than the viscosity of contrast. And you're probably asking, what is viscosity? Well, viscosity is how thick or thin this contrast can move in a solution. So of course, contrast is thicker and saline is less viscous. So then you would actually, or more viscous. So then what you would do is you would increase the flow rate by 1 millisecond. I now have a patient, a person, Xiao Quan Zhu. Does the 100 ml saline go before or after the contrast agent? Excellent question. It must always go after the contrast agent, because remember, we're trying to push the contrast into the right places. So excellent question. Thank you so much. Another excellent question I've just received from Mamta Chand is, what makes 370 move like blood as compared to other strength of contrast media? Fantastic question. Let me tell you, the molecular structure of contrast, if you look up the American College of Radiology contrast media manual, you look at the viscosity of contrast relative to blood. You see, blood is about 8 millipascals, and that's the pressure of how blood is moving. If we're looking at UltraVis 370, you're looking at anywhere between 9 and 11. If you're looking at a dimer, which is apparently meant to be the safest contrast in the market, which there is no actual documented evidence in literature, that's moving at like 14 to 16. So it's a lot slower, because the dimer is a double molecule, and so it moves a lot slower compared to the single molecule, which is the monomer. That allows the contrast to move a lot better. So that was a fantastic question. So let's have a look at now, when we look at issues between UltraVis, which is a monomer, and a dimer. In this patient here, we get liver perfusion deficits. What happens is, because of the blood lipid levels, or also because of if we didn't use saline, or if the viscosity of contrast. Now remember, everybody, each contrast manufacturer has a different viscosity profile. And if I'm only talking about the evidence that is actually seen in the FDA, as well as the American College of Radiology, the Chinese Radiological Association, as well as the European Society of Urogenital Radiology. This is all based on viscosity. Now, the viscosity here, as you can see, this is a contrast media, a dimer. So it hasn't perfused properly in the liver, because you had actually a early stage of fatty liver, or liver or hepatic steatosis, or liver cirrhosis. These are the 3 terms used interchangeably. And also, they never used saline to push that contrast. So normally in the arterial phase, if you look at the top line here, you see that, oh my goodness, this looks like there's a lot of lesions within the liver. But in actual fact, you actually had to do a venous phase scan unnecessarily, and it showed there was no perfusion deficit. This is because your patient is dehydrated, they've used a dimer as a contrast, and also, and this was a paper that was published in LIRADS, and also we never used saline to keep the contrast pushing through. So now let's talk about the summary of contrast media delivery in liver imaging. Remember, we talked about injection flow rate, and the faster you put your contrast in there, the faster it's going to go. But you have to remember one key factor here. The most important thing when we're looking at contrast media delivery, the heart can only accept so much blood and actually pump so much blood out. So when this happens, if the heart cannot push it out, it then pushes the contrast back down into the inferior vena cava, which goes into the hepatic veins. And you get this artifact. And this artifact is very, very prominent when you're having high flow rates. So whenever you're doing contrast media delivery parameters or injections, having very high flow rates actually works against us. Remember, if you're a 16 slice CT scanner up to 64 slice, you can go to 3.5 mils a second is absolutely fine and perfect. If you go from 64 slice to 320 slice, you can go up to 4.5 mils a second for the angiogram. Very, very important. Now we look at iodine concentration. Now this is key now. If I look at increasing my iodine concentration from 300 to 370 density, I've just increased my density by 25%. But now, remember we talked about KVP. If I reduce my KVP from 120 to 100, I approximately save about 33% in radiation dose. But more importantly, I then further increase my density by 25%. So by using 370 density, by using a low KVP, I've doubled the attenuation profile within the liver and the tumor. But more importantly, my contrast gets to the right place at the right time and through every single structure. This is what's key. So what are the biggest issues in terms of delivery? So we've talked about breathing. We've talked about saline. We've talked about injection parameters. But there's one thing we still forgot to talk about is venous pinch. A lot of the times we tell our patients to put their hands above their head, okay? And when we put the hands above the head, we actually squash the brachiocephalic vein. Instead of putting their arms above their head, let's get them to place their arms on the CT machine. And so as they move in and out, the contrast is not going to be blocked and will get through really well. The second thing is we always should use a right side contrast injection approach. The right arm is always better than the left arm is because the left arm travels a lot further and will mix more with blood than the right arm because it's when it goes to the superior vena cava. We always like to use 18-gauge cannulas. We always love to have saline chasing or saline flush after the contrast. This is because when the contrast is injecting through, we want to keep pushing it through. Also, we would love to have the elbow joint nice and straight because that's where the cannula is going through, and we don't want the cannula actually to kink. And most importantly, we're going to talk about test bolus techniques. Now we have Sarah Lim who says that since the liver could be a dense organ because you could have increased iron in it, how will it affect the image quality of the liver parenchyma when you reduce KVP? Absolutely fantastic question. So remember when we said that when we're looking at lesions, we look at the lesions relative to the liver parenchyma. And so what happens is, because you have a dense organ, this is why it's more important to have denser contrast. And this denser contrast allows you to see that large differentiation between the background parenchyma. So Sarah, that was a fantastic question. And this is the biggest issue that we're facing. Now let's talk about CT enhancement patterns. So usually when we look at contrast media, we will like to look at, we'll do a pre-contrast scan of the liver. We should always do a late arterial phase scan. If we do early arterial, remember only contrast is getting there through the hepatic arteries. But remember, we also need contrast to come back through the mesenteric venous system because that's where 75% of blood is flowing through. And 75% of the 1.5 liters of blood that's running through the liver per second, this is where the enhancement is. And then we also have the portovenous phase, which is usually at 70 seconds, and a delayed phase. Now, this is important. The delayed phase here is where we should look at anything from 10 minutes and above. Some people say 3 minutes, some people say 5 minutes. If you look at literature, it's a minimum of 8 minutes, but more importantly, you want the contrast to go through, either it washes in or washes out of that lesion. Now, we have an excellent question from Lorraine Hood, which I know very well from Australia. Can you explain why 18-gauge cannula is preferred than 20-gauge? And given it takes 5 mils a second, the 20-gauge. Fantastic question. Lorraine, you're absolutely 100% correct. I mean, we would like to strive for 18-gauge for all contrast media injections, but 20-gauge is absolutely acceptable. Definitely it is. And thank you for that. Now, we also have another question from Mamta Chand. What about image quality once we are reducing the KVP? So we actually, with reducing KVP, we get better low contrast resolution. What does that mean? The small hepatic lesions between 0 and 3 millimeters, we get to see them a lot clearer. So we will never mistake them for a hepatic cyst or a potential hepatic hemangioma. because there is a lot of evidence where hepatic hemangiomas have turned into metastasis or primary hepatocellular carcinoma. So this is why low KVP reduces the photoelectric effect and therefore gives me better low contrast resolution within the actual liver. Fantastic question, Mamta Chand. So if we keep going, let's look at the protocol. So I always structure my protocol to be exactly the same for all my phases. So if we look at the first line below the images, I always have a 100 kVp protocol for every single sequence. Second, I always use a fast rotation time. Because what happens is if I have the liver here and I have my lung there on top, it starts to flutter and you have differential movement. And this is because of breathing and the ability of the liver to actually want to push back up so we can push air back out. So it doesn't think you're underwater and you're suffocating. So that because remember, the liver, we're only scanning a small section of the abdomen. And we always want the pitch values to be exactly the same. Now, if we also look at the breath hold, make sure the breath hold's exactly the same. And then now let's look at the delivery. You want an 8-second scan delay, interscan delay. So if you're going to put the region of interest, if you're doing bolus tracking, at the top of the liver, and as you're injecting contrast, once it reaches there, the top of the liver, within 8 seconds, we should have an interscan delay because that gives enough time for contrast just to start coming back into the liver. Now, I've just been stormed by a lot of questions. Let me just go through them quickly. Okay, so from James Miro, from memory, LIRADS advises HCC and arrest delays between 3 and 5 minutes. Should these still be done at 10 minutes, like what would be for hemangioma? Absolutely. So a good question is, depending on what contrast media you're using, this is where the biggest factor of the LIRADS, and this is why we've had 12 iterations after the LIRADS, which was done in 2006, that we need longer waiting times for contrast. Now, if a patient is dehydrated, blood flow is going to move a lot slower and it's more sluggish. Second of all, the saline, if you're not using saline to push it, which is another factor. And third of all, if the contrast is not like the viscosity of blood, this becomes another factor. So yes, 3 to 5 minutes, but in actual fact, 10 minutes is ideal. So this is what we do in our institution. Now we have another patient, another customer, Wayutri Nuguru. Thank you so much for your question. It says, are you using a dual flow injection technique or partial on your injector? Which is better? Another amazing question. So I use 2 barrels. I inject my contrast and I have my saline to follow. When I talk about dual flow, this is another important area, okay? And now I use this mostly dual flow in my vascular and my chest oncology applications, which we'll talk about in 3 weeks or 4 weeks' time. Now, another question from Gokaran Prasad, thank you. How much contrast volume do you need for liver volumetry? Excellent. So I do a lot of liver volumetry for liver transplants or partial live or hepatocellular carcinoma resections. So I always use, remember, the contrast volume should be a minimum of 80 mils, but more important, it's the 100 mils of saline. You want to distribute the contrast equally. Because when you do liver volumetry, okay, what happens there is they're taking the average density of the liver parenchyma when they're doing it. And so you don't want to show that there is liver perfusion deficit, like what we saw about 6 slides ago, which makes it difficult for surgeons to actually cut and decide, can we use this functional liver volume or not? And functional liver volume is determined by the difference in density. So this is where 370 density is a lot more important. And thank you, Gokaran. That was a fantastic question. Now, would the contrast injection protocol be the same for 16 slice for Abhishek Gorlawar? Excellent question. So we said that 3.5 mils a second for 16 slice to 64 slice is perfect. And the rotation time at 0.8 seconds. Look, if 0.8 seconds is the fastest you have, depending on which scanner you have no other choice. But if you can get it lower, that's even more better. So now let's have a look at the issues of contrast media delivery and the different lobes of the liver, how they're enhancing at different times. Did you know that between the first lobe of the liver versus lobe 2, 3, 7, and 6, there's about a 2-second interval or difference in enhancement? And this is because of the direct blood supply coming from both the hepatic artery and the vein, as you can see in this graph. So that's why when we come to actually look at enhancement, we'd always want to do a late arterial phase, because every one of those 8 segments of the liver, we want them to be equally enhanced. Now, I've just had another question, and I think this is a really important question by, I'm sorry if I've said your name wrong, Gangaparappa. Can we mix different iodine concentrations in the same manufacturer's syringe? I would not recommend this at all. I'll tell you why. Because I have not read any literature or studies, and all companies actually advise against this. So it's like, would you mix, Fanta with Coca-Cola? It just doesn't work. And I would stay very far away from that. If you want to reduce the concentration in where you're trying to get at with this, then you could use dual flow. And this is really important to use with the Medrad injector. So if we have a look at the arterial phase, let's have a look what we'd like to see. We'd like to see the hepatic arteries nicely filled, as well as we want contrast in the portal venous system, because then we know that the actual 75% of the liver is enhanced. If we look at the portal venous phase, we'd want the portal system to be very heavily enhanced, as you can see with the arrows. And then also you want the hepatic veins, because we know it's going back up into the inferior vena cava. And then here, when we talk about the delayed phase, this is where, at 10 minutes, I like to have good distribution of contrast media. Now, remember, this patient right here, or this case, as you can see, there is high density of contrast, or there's high density in the liver. And this is because this is a fatty liver. This is why it's more important that beyond 8 minutes, you should do your delayed phase, so you can have enough time for the contrast to go in and come out. So if we look at pre-contrast, I now want to go talk into more detail now of each technique. It's good in detecting calcifications, fat-based tumors. Is there fat stranding or inflammation? Okay. In the early arterial phase, it's about 15 to 20 seconds. Okay, this is when arteries are really filled nicely, but as you can see in the image, the lesions are not enhanced. So that's why, even if you reach the 180 Hounsfield unit density of the abdominal aorta, it's not going to enhance very quickly, because within 3 seconds you've scanned the liver. It's not going to enhance those lesions. That's why we need an interscandal of 8 seconds for the contrast to get to the lesion. This is where it's important. If we look at the late arterial phase, this is where we've had contrast coming back. We've got good perfusion and tumors. Now remember, tumors are not just arterially enhancing. You can have complex arterial and venous enhancement. And then, of course, the venous phase, we've now have good contrast within the liver. The parenchyma is nicely and equally enhanced. And also there's still contrast in the second circulation coming through into the liver, which provides superior quality. So, and then, of course, in the delayed phase, we get to see what washes in, what fills in slowly, or what washes out. Now, let me talk about the importance of washout. If I look at a washout, it's important to understand that the different lesions have different structures. For example, if we look at the washout appearance, you can see this lesion in the arterial phase. You have nice in the top line of this liver. You have a heterogeneous filling of contrast media. In the venous phase, it's washed out, but the wall is still enhancing. And then in the delayed phase, the wall is still enhanced. If we go to the second one here, this is a hyper-enhancement capsular lesion that's nicely enhanced. And then in the delayed phase, we still have contrast in the liver, but what happens then is the contrast has washed out. So this tells me this is highly benign. responding to a question. Okay. So, and then if we look at also, sometimes you don't even get washout of lesions at all. So now we have to think about lesions. Does the lesion itself wash out? Or does the actual lesion border or the actual lesion, the rim of the lesion, does that keep enhancing or not? And this is something that we don't really pay attention to when we're coming to look at protocol development and timing. So if I look at this next slide, we have to think of there are three types of masses that we find in the liver. There's the nice, well circumscribed expansile mass. Then we have the infiltrative mass. So this is a mass like focal nodular hyperplasia, which likes to go out everywhere and go through. And then we also have non-mass structures, so which are perfusion deficits, or there could be infarcts or whatever. So it's really important to distinguish between these three structures. So let's have a typical look at enhancement. So this is one of my cases that we actually did, where we did this patient had hepatic steatosis. As you can see in the pre-contrast scan, they have high density within the liver. Secondly, the border of the liver is actually not smooth and marginated, it's actually jagged. So this tells us this is a patient has a fatty liver or whatever. In the late arterial phase, I've got good intensity or density of contrast that's within the hepatic artery and a little bit of contrast in the portal system. And you can actually see there is good distribution of contrast throughout the liver. When I go to the venous phase, my arterial system has completely washed out and I'm in pure portal venous phase. And you can actually see that the liver is brighter because I've got equal distribution of contrast. And then if I go to my delayed phase, I still have a little bit of contrast in the venous system because remember, in my delayed phase, we want to have contrast delayed at about 8 minutes and above, okay? And there's still contrast recirculating in there, but the density of the liver has just dropped back. The key here is I had Ultravis that distributed beautifully throughout the liver. I used my 100 mils of contrast. I used 100 mils of saline to push it and maintain the flow. I used the correct breathing technique, and I used 100 kVp. This is where you get really good imaging. Now, I've talked to you about what looks good and how do we make it perfect. Now let's look at the technical pitfalls. And this is where we need to now focus on injection flow rates. And this was an excellent question that was asked before. So this patient here is a 74-year-old man with a hypervascular hepatocellular carcinoma at the anterior segment. Now, if we have a look at this same patient that was scanned 1 week apart, the top two images are 3 mils a second and the bottom two images are 5 mils a second. So with a faster flow rate, we actually see lesions a lot better in the late arterial phase. But the problem here was they never used 100 kVp. This was used at 120 kVp. So you have to understand that using a combination of low kVp, 3.5 to 4.5 mils a second, we see fantastic filling of small hepatocellular carcinoma lesions. If I go to my next study, the importance of timing is that when we're looking at washout. Now, someone said to me, okay, I think it was James Miro, and James, the LIRAD said 3 to 5 minutes, which was a fantastic question. If you look at 3 minutes, if you look at the top row here, where we look at, 1 minute delayed, okay, of this same lesion, and I actually followed this lesion from arterial phase all the way to 5 minutes. As you can see, the lesion structure in the bottom line actually changes between 2 minutes, 3 minutes, 4 minutes, and 5 minutes. And you see how it's gone from non-well circumscribed to well circumscribed. What's really important here is that, and this paper was actually published in 2006, by the way, with low, the whole tumor actually looks better and larger, okay, when you have your delayed phase, because it's not the lesion that's enhancing, it's the parenchyma that's enhancing perfectly. And more importantly, this was not done at 100 kVp, it was done at 120. So the importance of having a longer delay time is important. I've just had another excellent question by Anil Pandit. Can we use 80 kVp? Absolutely yes. But remember, ladies and gentlemen, kVp, you have to use weight-based approach, meaning if I use 80 kVp, I only use this on patients that are like 70 kilos and below. Between 70 and 100 kilos, I use 100 kVp. Anything above 100 kilos, I'd always go 120 kVp. So fantastic. Now, I also have another question from Chen Dali. Can I have a lot of late arterial phase slides? My signal loss has just gone now. That's okay. We are recording this lecture and I'm sure they're going to give you access to it again. So don't worry. Okay. Now, let's look at respiratory misregistration. Well, we've already talked about this. What I want to say here is that we've talked about breath hold with the mouth open. But more importantly, I want you to understand that spend that time just to practice with your patient to say, look, we're going to ask you to breathe in maybe 10 times. And make sure out of these 10 times, your breath hold is exactly the same. Because as you breathe in, the liver also flattens and moves up or down. And it squashes with different breath holds. So we're going to actually potentially miss lesions if they're small. So, and depending on your reconstruction technique. So this is why this is really, really important that you pay attention to respiration and how it affects lesion detection. Now, I had another excellent question from Vanessa Malara. Thank you. Do you see a difference in enhancement between women and men? Well, fantastic question. I actually see a difference in enhancement based on the physiology of the liver. If you have a fatty liver, are you a large patient? Are you a thin patient? Do you have potentially thalassemia? Especially in Asia Pacific, ladies and gentlemen. You know, hepatitis is a big problem, and hepatitis is inflammation of the hepatocytes. And these inflammatory structures restrict blood flow into the liver. This is where I do see the enhancement pattern differences. That's why it's important to use 100 ml saline, a double barrel using 2 syringes, and using a high density 370 contrast that moves like blood. And this is where we give you guaranteed optimal imaging. So this is another slide which actually shows misregistration based on breath hold. So it's really, really important to look at this. And also remember that sometimes in the axial plane, when we do axial reconstructions, it looks like it's a lesion. But if we do a coronal plane, in actual fact, it ends up being an infarction. So be very careful that lesions don't show as lesions. There could be infarcts or restricted flow of contrast in that area. So that's why it's important to do axial and coronal reconstructions. Also, we can get what they call these pseudo lesions. And this could be due to poor or reduced enhancement. And this is where I want to come back and say, having a monomer gives you a better flow because you can get into the smaller spaces because of the liver disease. And if you have hepatitis or liver cirrhosis or a fatty liver, you have restricted flow into the liver and you have raised pressure within the liver. That's why it starts to expand and inflammate. So that's why you need contrast that moves like blood, and you need saline just to keep pushing it through as well. Someone's asked me for liver imaging, which is the best imaging modality? Well, let me tell you, ladies and gentlemen, you know, liver imaging it depends who you are and where you are. If you have a CT scan in your department and you don't have an MRI, well, you know what? CT is just as good. Now, let me tell you about MRI. MRI is a problem because if you don't use Primavist, which is a liver-specific or hepatobiliary-specific agent, then any other gadolinium just won't make it. So this is where you can't say is CT better than MRI. Let me ask you the question. Which contrast media is better for liver imaging and detecting lesions? That's the question you should be asking yourself. And that is that is a fantastic question. So if we look more again at this pseudo lesion, remember when we talked about patchy enhancement, if you look at the image to the right, this is the first lobe of the liver. Remember I said that at 3 seconds, there is a difference between 3 and 5 seconds between the first lobe and between the peripheral lobes of the liver. They have different enhancement patterns. So that's why having a contrast that is viscous as well as having saline allows you to do this. So, of course, you can also get more pseudo lesions everywhere else, and we have to be careful, and that's why the importance of washout at 5 minutes is important. Now, ladies and gentlemen, even though we've had an hour on this lecture, please remember that we're now going to start going through cases. Okay, so this is part of our case discussion, and I'm going to be asking you these questions. So also you can have what they call is transient hepatic attenuation. This is where we know that the liver is suffering. We know that there is inflammation. We know that you get these wedge-shaped appearances, but this is not because that the contrast we're using, it's because it's a combination of our KVP should be low. We should have viscous contrast media, which UltraVist superbly provides. We want high density of contrast, and we want equal distribution of contrast. So our waiting time from reaching the Hounsfield unit of 180 or 150 Hounsfield unit, wait 8 seconds to start your scan. And we actually alleviate all these pseudo lesions. Here we look at this. This is a metastasis that actually enhanced in the delayed phase. But if you look at the actual arterial phase or the portal venous phase, it looks like it's a hemangioma because the wall of the lesion is actually enhancing like a little Christmas tree. But if we look at the delayed phase, in actual fact, it's a tumor. So now we start our case history and our case load. Now, I want to look at tumors in the veins. Now, whenever you have lesions or tumors within the actual liver itself, tumors actually like to grow in blood, in the vascular structures, because this is where they have high abundance of oxygenation, nutrients, red blood cells, iron. This is what makes lesions enhance better. But let's have a look at the scan between the left and the right. In actual fact, if you're looking at this, the actual image on the right is a lot better than the image on the left. And I'll tell you why. The image on the left, he shows a tumor in the portal vein, which we can actually see with the actual arrow. But as the contrast is trying to get through, it actually looks a lot better because it's actually gone through, but you have a perfusion deficit within the liver. Whereas if you look at the image on the right, even though the contrast has gone through, but look at the difference in perfusion deficit. Now, ladies and gentlemen, the image on your left is a dimer. The image on your right is a monomer. This is the same patient scan with 2 different contrast media. So UltraVist, not only does it show the lesion a lot better, but it gives you good uniform enhancement within your liver when you're comparing with other contrasts. And this is why I'm saying, please understand, ladies and gentlemen, I'm very grateful to Bayer for allowing me to present my work, but also you are my colleagues, and I will present the truth in what we're doing, and everything is evidence-based practice. So now I want to look at lesions of the liver between benign and malignant-based lesions. I'm going to talk about the 4 most common lesions. This is lipoma, hepatocellular adenoma, hemangioma, and focal nodular hyperplasia. So if I look at a lipoma, it's usually fat within a lesion. You have a well-circumscribed border. You can see it quite nicely in the pre-contrast. But remember, the Hounsfield unit will be between -20 to -70 Hounsfield unit because it's a water-filled structure. And you have no soft tissue enhancement. But remember, okay, at low contrast, low KVP, I see the low contrast resolution is a lot better and my spatial resolution is higher. If I look at hepatocellular adenoma, now this is an uncommon liver tumor, and it's actually hormone induced, and they're usually solitary, so they're actually well circumscribed. They sit on their own, and that's only about 70 to 80% of these cases. And they usually can actually grow between 5 to 15 centimeters. It's nothing to be worried about. Now, if they are multiple, this is when there's usually more than 10 adenomas, and then they call it hepatic adenomatosis. And so these lesions are are usually seen in patients who are type 1 glycogen storage disease. So ladies and gentlemen, sugar is not something we should be using a lot in our diet, because the liver likes to thrive, so does our brains love to thrive on sugar, but also does cancer and growth of lesions. So let's have a typical look at the 4 phases. If I look at my pre-contrast, there is not, it's hypo to iso intense, enhanced lesion density. When I look at the arterial phase, I see that there is a well circumscribed, heterogeneously enhanced lesion. At the venous phase, more importantly, the actual lesion has actually washed out, but the wall of the lesion is enhanced. And it's actually equally enhanced as well, relative to the liver parenchyma. And then at my delay at 10 minutes, you can see the lesion has completely disappeared. To me, this is a benign lesion. Lesions that fill in and stay enhanced at 10 minutes, you're most likely going to have a malignant-based liver lesion. Now let's talk about hemangiomas. You know, these are benign, non-neoplastic hypervascular lesions. Or if you just think about a Christmas tree with light bulbs, they like to turn on and off, and they all turn on at once. Okay, and so from a radiological perspective, it's really important. Hemangiomas can look like metastasis and can look like hepatocellular carcinoma. So hemangioma could look bright and could look benign. But if my delay time is not long enough, you know what, ladies and gentlemen, there has been a lot of missed cases of hemangiomas which turned into be metastasis based on patients who have primary liver lesions. So if you ever have a patient who has a primary mass in the breast, in the brain, in the lung, or anywhere else, or in the gastrointestinal system, always prove that that lesion is a metastasis before you assume it could be hemangioma, because that then changes the patient's treatment outcome significantly. So the importance here is the hemangioma always give a good delay time. So let's just have a look at some hemangioma patterns. So if you look at the top row, you know, the pre-contrast scan, it is hypo-opaque, or it is the same density relative to the liver parenchyma. Then you have the arterial phase, which shows a nice, well-circumscribed border and multiple enhancement patterns. In this venous phase, it's starting to wash out. So you think to yourself, oh, could it be an adenoma? But then when we get to the delayed phase, the wall is still enhancing. This is typically known to be a hemangioma. If I look at the second line, in the pre-contrast phase, and remember there is high noise here, and this is a large patient, there is a hypoattenuating mass relative to the liver parenchyma. In the arterial phase, I can see that there are little enhancement bodies all the way around the actual liver lesion. In the venous phase, the structure of the liver has started to change, but it hasn't filled in. And then in the delayed phase, it's filled in very slowly. So this is definitely hemangioma, but this enhancement pattern occurs because it's a cirrhotic liver. Remember, cirrhosis of the liver is reducing the flow of contrast. This is why I once again will tell you, having a monomer with a viscosity profile like blood is more important than ever. Then we have another type, which is a focal nodular hyperplasia. Now, this is a regenerative mass lesion of the liver, and it's more infiltrative, like what we saw before. And it's the second most common benign lesion that is after the hemangioma, which is what we talked about. And they have a lot of radiological features which are atypical, which is very unusual. And, you know, patients usually are asymptomatic, and they can actually have, you know, no treatment for this. But the origin of focal nodular hyperplasia is due to be hyperplastic growth of normal hepatocytes with malformed biliary draining system. So if you look at the liver or the hepatocyte, you have your artery, you have your vein in the middle when the hepatocytes feed the blood flow in and out of. And then you have your biliary system, which, the toxins that the liver functions pushes them through osmosis or diffusion via gradient into the biliary system to drain it away into your biliary system and concentrate it in your gallbladder. So what happens then is there is a mismatch of pressures between the arterial and venous system versus the biliary system. And so what happens then is this backflow of toxins starts to increase the size of the liver and the focal nodular hyperplasia. So this is a typical example. It's quite large on the arterial phase. There is almost the same filling because it's slow filling. And then in the delayed phase, it completely washes out. And what's more important also, you have a small necrotic area in the center. This does not affect at all to tell us whether this is benign or not. But because of the small necrotic center, you know that this is benign. Whereas with malignant lesions, they have a large necrotic center. Because cancerous lesions, which are malignant, they love to recruit large and small blood vessels to increase the nutrients in there, but it also likes to kill itself internally so it can reuse those nutrients to keep growing. And so when we're looking at liver imaging and malignant-based tumors, we're looking at the wall of the lesion, what happens there. And we have talked about that with the enhancement pattern. Now, with the malignant lesions, we're going to talk about the three most common type that we'll find all over Asia Pacific and, you know what, potentially the world. We have hepatocellular carcinoma, we have cholangiocarcinoma, and we have metastasis. So hepatocellular carcinoma is very common. It's usually the hepatobiliary virus or, genome that contains genetic material in there which predisposes the cell to actually become malignant. And a lot of patients who have hepatitis C are highly prone to get hepatocellular carcinoma because of this genetic material internally. And what happens then is that the alpha protein levels elevate between 50 to 75% of cases. So when you're looking at liver tests, if you have a change in the alpha fetoproteins by more than 50 to 75% in a short period of time, definitely you have a large aggressive tumor that's growing in there. Radiographically, in CT, it could be focal or multifocal or diffuse. Now, remember we talked about before, which three, were giving the different types of infiltrations. Well, in hepatocellular carcinoma, you have three types. If it's focal, it's going to be a large mass, and it will have necrosis, fat, and it can have calcification. This is where the importance of back of pre-contrast is important. If it's nodular, which is multifocal, you could have multiple masses with variable attenuation. With variable attenuation, this is where I want to reiterate, the contrast medium monomer with the viscosity profile of blood, we reduce this kind of guessing appearance. And it could also have central necrosis. If it's diffuse, then it becomes difficult to distinguish between cirrhosis versus a different type of hepatocellular carcinoma. So even cirrhosis of the liver or a fatty liver or hepatic steatosis is also a precursor for lesions within the liver and for hepatocellular carcinoma. So let's take a good look at this example. So here I have a hypodense mass relative to the liver parenchyma. In the arterial phase, I actually see it's enhancing, but it doesn't enhance like hemangioma, but it does look very similar. And then in the venous phase, the wall is still enhanced. And then in the delayed phase, the wall is enhanced, but the lesion has gotten smaller relative to the liver parenchyma. This means that the liver lesion is still enhancing, but it's very slow enhancing. I have scanned patients with hepatomas. I have waited up to 2 hours to do a delayed phase, and it's still the lesion filled after 2 hours. So this is important when looking at an 8-minute delay with the LIRADs. They've actually had different iterations since then. With diffuse hepatocellular carcinoma, look at this in the arterial phase. Because this was an early arterial phase in the image to your left, we have perfusion deficit within the liver. So this is where, when you did it in the venous phase, in actual fact, look at the lobes of the liver between the left lobe and the middle of the right lobe, and in actual fact, you have tumor within the portal system. And then when we look at the delayed phase, it's completely filled in with contrast. This is a diffuse hepatocellular carcinoma. But what are the errors here? They never used saline. The density of contrast was not dense enough. They didn't use a low KVP. More importantly, the monomer did not diffuse equally and perfectly, and our waiting time wasn't right. It should have been at 8 seconds. So what I'm trying to show you here, that delivering your contrast media with the combination of these techniques really shows and portrays the enhancement patterns of these lesions. Then we also have multifocal hepatocellular carcinoma. This then can look like metastasis. But here, have a look at this patient. This is a large obese patient. He has a fatty liver. But look at the density of the contrast. Did you all notice it's very dense? Did you all notice that the lesions are enhancing beautifully and almost equally? Did you all notice that there is equal distribution of contrast within the liver? Ladies and gentlemen, this was an UltraVis 370 dense contrast with 100 mil saline using 100 kVp technique. So this is where you have good attenuation. And this is where I really suggest in the imaging we go 370. Cholangiocarcinoma is a very aggressive tumor. The life expectancy of once getting it is between 1 and 2 years. And it's typically homogeneous in enhancement pattern. So if I have a look here at this image here, this is, again, reference this, and this is taken from the LIRADS. The cholangiocarcinoma can enhance, the wall enhances, and then the wall starts to fill in. This is very, very important because this is exactly what we talked about with hepatocellular carcinoma. So let me show an example. Here on the non-contrast, it is hyper-attenuating relative to the liver parenchyma density. In the cholangiocarcinoma in the arterial phase, you have multiple septations and you have equal wall enhancement, but look at the liver. Then in the venous phase, you have good distribution of contrast within the liver, and then the lesion is filling in quite nicely. And then at 5-minute delayed, the lesion has filled. This, I would have liked this to be a 10-minute delayed because then the entire lesion would have filled and would have been dense relative to the liver parenchyma. Liver metastasis, it can come, it's 18 to 40 times more common than primary liver lesions. It can come from the GI tract, breast, lung, genitourinary system, patients with melanoma, sarcomas, or any solid malignancies. And so usually the CT patterns, it's hyper-attenuating on non-contrast. Enhancing is less than the surrounding liver tissue. And of course, if you have hepatic steatosis or a fatty liver or hepatitis, then it gets even worse. So normally if we look at liver metastasis, you could also get hepatic lymphoma with it. It becomes hypervascular, low density center because we talked about it likes to kill itself so it can keep growing. And also, you can also have cystic metastasis, ladies and gentlemen, where you have a fluid level in there, you start to see unusual debris, and you have some nodules. So if you have a look here, metastasis looks different for different types of lesions, which are based on primary tumors. So the one on your left is a typical colorectal primary tumor, and this is the metastasis. And then also in the gastrointestinal system, you have a rectosigmoid carcinoma, metastasis that's actually gone into the liver, and the enhancement patterns are different. So this is where, and you can actually see the image on the right, you can see good wall enhancement, you can actually see debris in there. So then if we're looking at a liver mass, we have to look at, this is a nice little table that I took from, which was published in 2013. We have to look and say, okay, do I have enhancement of the lesion? Yes. Then we have to think to ourselves, it could be hepatocellular carcinoma, cholangiocarcinoma, or metastatic tumor, or it could be benign. The only way we can know between malignant and benign is having a washout phase. Now this washout phase, if you actually look, if it completely washes out relative to liver parenchyma, then we're going to actually know this is metastatic in nature, but we don't know until we have the right timing. And it's also the opposite with adenomas. Now, to get this right, radiologists can do this very, very well. But more importantly, then they'll go through a biopsy to confirm diagnosis. So really, really importantly, lesions and enhancement patterns. Using UltraVis 370 provides a great platform to actually give us consistent and confident contrast media enhancement of both the liver and the lesions. But more importantly, because UltraVis is the closest viscosity to blood flow, it can actually get into those small little vessels and into the walls of these lesions and have good enhancement. Second thing, low KVP. Third, double barrel. Use 2 syringes. Please, ladies and gentlemen, do not multi-use your syringes, because if a patient has hepatitis, you could infect that patient with hepatitis if you're multi-dosing. So always use separate syringes and turn them over. I know there could be a financial issue behind it, but I will say this: if this was your mother or your father, brother or sister, would you expect me to give your parents a clean syringe, or do you want me to use it because of someone else? I really believe in this. Third, breath hold technique, imaging parameters. So all of this here allows you to put the picture together to get good optimal imaging techniques. And ladies and gentlemen, don't do big changes in your department straight away. Go and have a discussion with your colleagues, speak to radiologists. You can look me up online. I have a lot of publications. We have done a lot of work with Bayer, and Bayer has been an excellent partner in helping me do my research. And so out of this, I'd like to thank you all for listening. Please, you can jump on my website. It's free to use at mdct.com.au. I'm eternally grateful to Bayer for allowing me to present my work from home in this coronavirus pandemic. All of you out there who are working at the front lines, I am so 100 years. Radiology has always been at the front because we do the X-rays and the CT scans. And monitoring radiation dose, having good contrast media delivery, the patient always wins every time, every single time. So a big thank you to you all. You have all been amazing. And now we'll open up the floor for questions and answers. And I'm already seeing a lot of thanks. So from Sam from Malaysia, Nina from Lebanon, thank you so much. I also have my students from a few universities around the world that have logged in, from Lebanon, Canberra, which is Australia. And we've got people from Ireland. So this is great. Thank you so much. And to my friends in Pakistan, India, thank you so much. China, you guys are amazing. Vietnam, Indonesia, I've seen all of you there. So a big thank you. And I really, really appreciate the time you have given to me and to Bayer to present our work. So any questions? I'm seeing all these thank you, professors, and thank you all. But I've tried to answer a lot of them as we've gone through, and I really appreciate it. Lorraine, big thank you to you. Thank you for coming on board. Also, we have Qatar, Arif Abdul Majid. Thank you so much, Arif. Multi-use system in Maxeon supply in Australia? That is an excellent question. I could like to answer that. She's more closely involved with that. Leona, would you like to take the floor and answer that question from Samuel Underhill, which I know Samuel very well. So thank you, Samuel. It's a great question.
Sure, Charbel. I hope everyone can hear me. So we're talking about the Centago, which is a new system that's just going through I guess we're calling it a controlled commercial release in Australia. And I'd say one of the main differences is that this system is designed completely with safety in mind, designed specifically for safe usage of a day set that lasts for 24 hours, and then we have the single patient line, which obviously you change per patient. So I think where Professor Charbel was advising you around not to reuse your syringes, if you allow me, Charbel, what he's referring to that are single use only. So those syringes were designed, the systems were designed to be only used once with the syringe and then thrown away. There's no other safety features in there to help protect from accidental cross-contamination. Whereas a system that's designed for multi-use has all of these safety features built in, and they're tested and so forth. So I guess this is the main difference, is we, I guess at Bayer, have what we term on-label use. If a system is on label for multi-use, that means that it's been tested, it's gone through very, very rigorous testing around bacterial encroachment, all the things like that, and you know then that that system is safe to be used in the way it's been approved. If it's a single-use labelled system, then that system should not be used off-label in a multi-use situation. I hope that helps answer the question, but certainly we can follow up with your local team anytime. Thank you. Thanks, Charbel. Back to you, the expert.
Oh, thank you so much. I mean, look, I've had some questions about CTA, what are the minimum flow rates, from Rui Fernandez. Rui, thank you so much. Look, I would love to answer it here, but please, we're giving about 9 lectures every week for the next 6 or 7 weeks. So I have a dedicated CTA lecture series for that. You're great. The guys, I'm going to give you all shout outs individually until I get a question. Sam. Me and Leona, in terms of multi-using, now this is, and TGA, this is a big question, and it'll be fine. The world is moving in the right place, and Lorraine, it's always great to hear from you, and thank you for hearing me. Vanessa Malara, yes, I will stay safe. Thank you so much. And Michelle Punch, a great friend. Thank you so much. We love you too. Mr. Chang, thank you. Samuel, nice tips, great. Sebastian Gonzalez, this is excellent. And Sebastian is from London, so big thank you for coming online. Please share the news, everybody. These are open to everybody and it's free. And, you know, big thank you from Judith from Switzerland, Judith Week. I really appreciate it. Samantha Brinsmead, oh, it's been a long time. We used to work together about 10 years ago at Royal Prince Alfred in Australia. Big hello to you. Rui from Hong Kong, thank you. And I hope you're safe there. I know you guys have done a great job. Lydia Seyman, yes, I know. Dennis Khan, yes, great guy. So it sounds serious. We've moved because in terms of answering this, we'd have to look at the literature and the data. I don't like to talk things about that I have not researched about it and understood it. So I'm going to have to be sorry, James, I can't answer that question at this point in time. However, I'm more than happy for you to send me an email. You have my email, info@mdct.com.au, and I'll be happy to answer it for you as well. Mohammed Amir, for liver imaging, are you preferring arterial phase or late arterial phase? So Mohammed, I really believe that late arterial phase for oncology is perfect. If you're doing liver transplant imaging, you should do early arterial phase. Dr. Ria Sublock, thank you so much for the gratitude. It's really nice. Dennis Khan, is there a schedule for these webinars? Yes. Every week, same time, same place, same day, we're going to be giving you a lecture every week for the next 8 weeks from memory, or next 10 weeks. So yes, Chavrat, it is my pleasure. Mr. Danny Santo from Indonesia, big thank you for coming online and for the many thanks. Nina, can we print the seminar or save it? Maybe Leona could answer that question. Leona, will we be having people able to have access to this lecture?
Thanks, Charbel. So we are recording the lecture tonight. So we will make the recordings available to the local Bayer teams in the countries. So I think they will, I'm not sure exactly what each country's plan is, whether they can share it with you or maybe even host another viewing at your hospital. Obviously, we can't visit hospitals for many countries at the moment, but definitely reach out to your local Bayer representative, and I'm sure we can help you out.
Excellent. Uba from Indonesia, thank you. Tudiongang. Now, I have a great question. I noticed that you use different delayed times to assess washout phase in different hepatic masses. What are the factors that determine the delay time that you use? Fantastic question. Tudiang, let me be very clear. I always like to use 8-minute delay time. And this gives me good consistency and for all my lesions. So once we get accustomed to that, that's perfect. The last thing you want to do, more importantly, is every person doing something different. And this is where Bayer have found this issue. Everyone is doing something different. So we want to streamline, we want consistent imaging, we want consistent techniques and protocols. Now, Rui has a question. Patient fasting, the 4 hours, is it still ideal or could we reduce fasting time? Rui, that is a fantastic question. I'm so glad you asked, because in the old days when we had ionic contrast, people used to vomit. That's why they had the 4-hour rule. Now, these days with non-ionic and contrast media reactions, our patients, if they're well hydrated, meaning, 4 hours, they become dehydrated once they get to our CT scan. So keep them on clear fluids. People are not vomiting like they used to anymore with ionic contrast. And this is the myth. So, get them to fast on solid foods, not from fluids, and that helps you a lot better. All right, here we go. And now we have another question. Madhuri Sahu, is MRI or CT better to differentiate lesions? Again, I think I've answered that question, but I'd love to answer it again. It's not which modality is better, which contrast media is better. So if you have MRI and you're using extracellular gadolinium, well, it's fine. But if you use the Primavist or Iovist, depending which part of the world it's called, it's a hepatocellular specific contrast. And so that's where the beauty of that is. Henry Lung, okay, there's a nice question here. Hello, I know there is a spectrum between HCC and cholangiocarcinoma in between. Radiologists call it cholangio HCC. Is the CT feature of cholangio HCC just a mix of HCC and cholangio? Anyway, stay safe. Thanks, Henry. I know Henry very well. He's a great guy. That's a really good thing. That's based on the enhancement pattern and the lesion. Remember, we saw it. It looks like hemangioma. It could be cystic hepatocellular carcinoma, or it could be cholangiocarcinoma. And it all comes back down to the contrast media and the waiting time. I can't answer what certain radiologists say, but in this instance, in imaging technique, we need to differentiate these lesion enhancement patterns, and that's what's important here. Yi Ling or Sarah, thank you so much. Gokran Prasad, which contrast agent is good for liver MRI? Again, good question. I think we'd leave this for the experts in Bayer. I think I've answered that. Claire Chow, hi Charbel, the late arterial phase, can I use a timer set at 35 seconds instead of bolus tracking? That is an amazing question. Let me tell you something. Every human body is different. Every heart rate is different. Every cardiac volume or the amount of volume of blood leaving the heart is different. If we're using just a fixed scan delay of 35 seconds, you're actually guessing that, or you're assuming that everyone is pumping the same amount of blood out of their heart. Test bolus, we confirm that, and there's been a lot of studies on this to actually dismiss a fixed scan delay. You'd always want to do it through bolus triggering. Hi, Maggie from Hong Kong. It's an absolute pleasure having you here. Pranav Malaya. Is there a different ideal delay time between cirrhotic and non-cirrhotic? Absolutely. That's why with the 8 seconds, I take into account hepatitis and cirrhotic liver. So by adding an extra 2 seconds, we get good filling. So that's why 8 seconds into scan delay is good. Now, I have a question from Salam Al-Hamara from Lebanon. Thank you, Salam. They're now using 2 hours delayed liver. And she used to be the head of CT in my department until she left to become the boss of a big radiology department for the whole Middle East. So well done to you. Iu Ka-chun, as for poor patient condition, what do you suggest is the slowest flow rate of contrast for liver pathology? If a patient is, 60 kilos or 70 kilos, you can go to about 2.5 mils a second or 3 mils a second. But I really push against that. I really would like that. Rasha Aitani. Rasha is from Lebanon, and she was my former student. Now she's a great sonographer in vascular. What about diabetic patients? How should we change our concentration, and to which extent can we dilute the contrast to maintain low contrast resolution? So with a diabetic patient, I really believe that not just reducing contrast volume, because in diabetes, the most important thing is its hydration status, because they have a fast cardiovascular network or cardiovascular time. So they're actually going to be dehydrated a lot more. And with diabetes, you want to reduce the amount of contrast volume. That's why it's more important to use 370 density, because you can allow for that. Now, I have a patient from That Nam Alton. If patient's weight is more than 120 kilos, how much contrast media is proper to inject for a dynamic liver CT? Well, I would go to 150 mils of contrast at 370, plus I'd use 200 mils of saline. Because so for every 10 kilos a patient is greater than 100 kilos, you're increasing the blood volume by 100 mils. So if you've got a patient of 140 kilos, that's 400 mils extra of blood that's moving in the body. So you need that higher volume, but saline is good. I have a question from Gwen Huang. With liver CT, is it always better to use injectors or hand injections? Wow, amazing question. And this is something that, again, we go back to how do we provide consistent, good quality imaging every time? Well, the only way to do this is by using a mechanical injector. Now, let me tell you why. We have done a study, or I've done a study, where we looked at the difference between radiologists, radiographers, and nurses when we used a mechanical injector versus hand injection. We actually found that with the hand injection, you actually end up giving higher flow rates and pressures than the mechanical injector. So this is why you would want to stay away from this. Another question from Tsun Wei Hu. As a protocol we use in Hong Kong for liver CT imaging, we only allow for a 5-minute delay. Would you say that that's not long enough for most liver disease differentiation? Fantastic question. Look, I prefer to have 8 minutes. If you can add another 3 minutes, that'll be fantastic. But again, really have to think about this.